It's a real honour to be here today and to present to you some of the research that I've been involved in Glasgow and really reflect on probably more the future direction of the research that I've been doing. I've known Martin for a couple of years now, and we've been able to work on a couple of projects together, some of which will be reflected in this presentation because we've done some similar research over the years, and just really keen to hear your thoughts on particularly some of the more recent work that we've been doing. So I thought I should probably give you a little bit of context about Scotland. Not everyone will know where it is. It's a very small country. It makes up one of the 4 nations of the United Kingdom at the moment. Anyway, that may well change in the foreseeable future, but we're waiting to see what happens in the next year with Brexit. And it's over 17,000 miles from Sydney here, so it's a long way, but a very lovely country, and I would advise you all to come and visit. So, as I said, it's a very small country. The population is just over 5 million. The largest city is Glasgow, where I am based, but the capital is Edinburgh, and they're on either coast of the city, and a real rivalry between them as well, as you'll probably find out if you ever come and visit. But in addition to the 2 big urban centres, there's a real range of rural, remote and island communities, some of which can be quite far away from the main urban centres of Glasgow and Edinburgh. Nothing on the scale of what you have here in Australia, of course. Scotland as well has quite a poor health record in comparison to other European countries, and there's considerable inequalities in the country between different social groups and also between different regions. So the average life expectancy within Scotland is 77 years for men and 81 years for women. But this falls to 68 years for men and 77 years for women in the most deprived areas of Glasgow. So healthcare has devolved to the Scottish Government within the United Kingdom. This is a picture of our quite striking Scottish Parliament, which is in Edinburgh. And health services are available free of charge via the publicly funded National Health Service. Health's delivered across Scotland via 14 regional health board areas, and they work in partnership with the local authorities, so the local councils, to provide integrated health and social care. And their remits cover both community health but also health improvement. So the Scottish Government has just recently published some new public health priorities for Scotland, and these are them here. So they want to encourage a vibrant, healthy country with safe places and communities, a Scotland where we'll flourish in our early years and where we have good mental well-being, where we can reduce the use and harm from alcohol, tobacco and other drugs, and have a sustainable, inclusive economy with equality of outcomes for all. And a Scotland where we eat well and have a healthy weight and are physically active. So these are all very worthy endeavours to be aiming for, and really in terms of the work that we do and the unit I work within, these are areas that we're focused on, but within the context of thinking about how the social determinants of health really drive these public health priorities, and how if we can address those, we will hopefully have better hope of actually achieving some of those aims. So the unit that I work at, the Social and Public Health Sciences unit, was joint funded by the Medical Research Council and the Scottish Government Chief Scientist Office, is based at the University of Glasgow, which is one of the oldest universities. And has just over 25,000 students, which I understand from Martin is probably similar to the number of students here at UNSW. The unit's aim is to improve health and reduce inequalities in health through the study of social influences on health and well-being, as I mentioned. And most of the work that I've done in the time that I've been in the unit, which is coming up on 20 years now, has had a focus on sexual health research. So we've done a number of studies focused on women's reproductive and sexual health, and then also a number of studies working specifically with gay men around issues to do with HIV testing and broader sexual health as well. And that's really what I'm going to focus on today. So as I said, much of our work is focused on working with the diverse and varied gay communities that live within Scotland. And in the time that we've been conducting this research, we've seen real major changes in terms of both the experience of disease and of health. So we've had the advent of biomedical HIV prevention, but then also the blossoming of anti-discrimination and equal rights legislation. So today I'm going to talk you through some of the changes we've seen in terms of gay men's health within the Scottish context, but also reflect a little bit about the future challenges that we see for gay men's health and well-being. And I'm going to focus on syndemic theory and how we might apply this to our understanding of health and of particularly of the health inequalities that gay men experience. I'll talk briefly about opportunities for a new community participative approach that can take account of this changing context and the changing norms and practices that we see. And I'll finish very briefly with some future directions of how we might use this approach with other marginalised communities and populations who we know are at risk of poor health. I'm going to try and get through all that in about 40 minutes, so just give me a nod to see if I need to hurry up a little bit. So much of what I draw in the presentation today comes from the Gay Men's Sexual Health Survey, which I led at the unit until just recently, and it's now been handed over to a colleague at another institution. This has many similarities to the Gay Periodic Survey that Martin has led on, and there's a lot of comparable questions in terms of the data that are collected. It's a cross-sectional questionnaire, and since 2005 we also collected oral fluid samples to test for HIV. We use time and location sampling to survey the venues, specifically bars, within the two main cities, Glasgow and Edinburgh. So that over the course of a 2-week period, we visited all of the bars at 2 different time points in each day of the week. We also included saunas within the survey. These were visited less often and at the most frequent times that the owners and managers advised us would be appropriate to come. And between the period of 1996 and 2014, we surveyed over 12,000 men. There has been another survey conducted in 2017, led by my colleague Jamie Francis. I'm not going to talk about the data from that today. It's used a slightly different methodology and dry blood spot testing instead of oral fluid sampling, so we've not yet compared the two data sources. The work that we've done in Glasgow has also been complemented by a programme of qualitative and online research with my colleagues here. So Nicola Boydell was one of my PhD students, and she conducted a study, a qualitative piece of work looking at young gay men's personal communities and experience of HIV testing. Ingrid Young worked with me and led on a project, the HIV and the biomedical, to understand the acceptability and willingness of both gay men and African communities within Scotland to use both treatment as prevention and PrEP. This study was conducted before they were widely available. We conducted a large online survey of gay men within Scotland, the SMASH survey that's led by Jamie Francis at Glasgow Caledonian University. And with Paul Flowers from Glasgow Caledonian, we've also conducted some evaluation work and some more detailed qualitative work that we've used to complement the survey that I'll be talking about today. So let me start with the progress and challenges in improving gay men's health. So you'll all be familiar with the 90-90-90 targets set out by UNAIDS, and we've looked to see how Scotland has got on in achieving these targets. And you can see that in terms of the proportion of achieving viral suppression or untreatment, we are meeting those targets, but still falling short in terms of the proportion diagnosed. These data are slightly old now, but they haven't yet been updated, so they're the most recent ones that I have. So just going back to that for a second, looking at the proportion who are undiagnosed at around 17%, we can compare this to the proportion of men in the bar surveys who've tested across the course of the dates that we've been doing the bar-based survey. And we can see that there's been a real significant increase in the proportion of men who took part in the surveys who did report HIV testing. So when we first started conducting the surveys in 1996, just half of the men had ever had an HIV test. And this increased to 83% at the last round of data collection in 2014. The proportion who tested recently, so within the last 12 months, increased from 28% up to 59%. And the proportion testing in the previous 6 months, so very recent testing, has increased from 13% up to 40%. More recently, we've started to look at the proportion who've tested in the last 3 months as testing guidelines have changed and as PrEP has become available, but we don't have trends data in that yet. So in terms of the survey, we were always interested as well in trying to understand the proportion of undiagnosed HIV infection within the population. And the BAR survey was actually the only measure of undiagnosed HIV amongst gay men in Scotland for some time there. So when we first started collecting the oral fluid data, we found that the proportion of men who had undiagnosed HIV was high at 41%, but this fell between 2005 and 2008 to 26%. In 2014, we saw that it rose again to 38%. The numbers involved here are very small, so I'm not talking about statistically significant differences, but this does compare to the national estimate of 17% who have undiagnosed infection. So this does seem high. And when we've looked at the men who tested positive in the survey but hadn't had an HIV diagnosis, almost all of them told us that they had tested for HIV within the previous 12 months, really highlighting the need for frequent HIV testing. So we looked at the data that we had in comparison with some other surveys which have been conducted in London using very similar methodology, and also the Scotland-wide online survey, the SMASH survey, to try and interrogate a little bit more around the frequency of HIV testing and patterns of this amongst the populations that took part in our surveys. And we found that just over half of men reported annual HIV testing, and fewer than 1 in 5 reported very frequent HIV testing. So 4 plus tests in the previous 2 years, taken to indicate 6 monthly testing. Annual and frequent testing was more likely amongst men who were at higher risk of HIV, but the differences weren't significant in multivariate analyses. And at the moment, UK HIV testing guidelines recommend that all men test at least annually, and men who are at high risk of HIV infection test every 3 months. And we can see here that within the survey data that men were not yet meeting these testing guidelines. So what we next investigated was to find out whether or not there had been changes in testing norms within the population taking part in the surveys within Scotland. So we compared the data that were collected in 2000 with that collected in 2010 to try and assess changes in community level perceptions of barriers to HIV testing. And at the community level, we could see that the benefits of testing and HIV testing norms did increase over this time period. However, other perceived barriers, such as fear of receiving a positive result, and clinic-related barriers, and attitudes to having sex with positive men had not changed over that time. So it didn't seem that there had been a broad, wide community-level change in norms to fully impact on HIV testing levels. Reflecting on some of the clinic-related barriers to testing, we were aware of the fact that new testing technologies were becoming available, and these may well address some of those clinic-related barriers. So the self-test for HIV, which is now licensed in the UK, is available not yet on the NHS, but to be purchased online. So we were interested to see if men were aware of this technology that was coming and if they would be willing to use it. So the self-test was licensed in 2014, just around the time that we conducted the 2014 survey. So these data are still hypothetical in terms of asking men if they would be willing to use the self-test and if they were prepared to do so. We combined the survey data with some qualitative work that we conducted with through expert focus groups with gay men, NHS staff and community organisations within Scotland. So what we found, first of all, is that 89% of the men who were surveyed reported that they would be willing to use self-testing. Many said they would do so instead of having to go to a clinic, but others also talked about using the self-test after having a risk event, after a condom bursting or having unprotected sex. And this raises implications for the understanding of the testing technology and also the window period. When we looked at the qualitative data in terms of the acceptability of use of the self-test and the barriers and facilitators to use, we found that there were many facilitators that would encourage use of the technology. It was seen as being convenient, it afforded privacy, and was also a means by which you could rationalise resources within the clinical setting. It would reduce pressure on clinics which were already struggling in terms of the numbers trying to access them. There was some suggestion that it would help to avoid the stigma associated with testing, and this was seen as a positive. There were a number of barriers as well, though. So there was a fear that through promotion of the self-test, there would be lost opportunities for engagement and for engagement of men within a holistic health model, means of promoting testing for other STIs, but also considering the sexual and mental well-being of men coming through the clinic settings. There was fears about isolation and low trust in the method and how to use it, and a concern that you would need a high level of health literacy in order to use the test. And overall, we could see the potential for an unintended consequence of the testing technology in that it would miss the opportunity for further health improvement. You're all very aware of PrEP and its availability now. And at the last survey, we also asked men about PrEP. This was before it was available within the UK. So again, this is very much hypothetical in terms of understanding men's willingness to engage with the technology when it became available. Using the quantitative data, again from the survey, this is from the SMASH survey, the online survey. When we conducted that in 2014, just under 1/3 had heard of PrEP, and awareness was associated with living in the larger urban areas within Scotland, having university level education, and being more likely to use the gay scene. Men who were aware of PrEP were also more likely to have tested in the previous year. Half of the participants told us they were willing to use PrEP, and willingness was associated with younger age and the reporting of higher risk condomless sex. When we looked at the qualitative data, again we saw a complex interplay of risk perceptions and patterns of sexual practices, which could really affect the motivation for PrEP use. And what we've concluded from this was that there's a potential patterning of inequalities in both awareness and acceptability of PrEP within the population taking part within the surveys and the qualitative study. And we need to think about how we ensure equity of access and awareness amongst diverse communities of gay and other men who have sex with men. So the work that we've conducted in terms of PrEP has then went on to inform the Scottish Government's decision to fund PrEP on the NHS in Scotland and make it available to gay men, or men who have sex with men, I should say. There's very strict criteria around who can access PrEP and when, but since July last year, when it became available, over 1,200 men have accessed PrEP. Along with colleagues at Glasgow Caledonian University, we've just started a formative evaluation of this early implementation of PrEP within Scotland. That's led by Claudia Escort at Glasgow Caledonian University. What we know anecdotally in terms of what the clinics are reporting to us already is that the clinics are identifying candidates for PrEP. So men come into the clinic for HIV or other STI testing and are being informed about PrEP and are then given access to it. What we don't yet know is how that information is diffusing out into the community more broadly. So to reflect and sum up on the first section of the talk and some of the challenges ahead, you can see that the data that we've collected over the last 20 years has provided a unique insight into the sexual and HIV testing behaviours of gay men in Scotland. We've seen a substantial increase in HIV testing amongst men across this time, and the perceived benefits of testing and testing norms have increased as well. However, current UK guidelines on the frequency of HIV testing are still not being met, but there is evidence of willingness to engage with new HIV testing technologies and biomedical HIV prevention. However, we sound a note of caution in terms of how these technologies could have the unintended consequence of amplifying health inequalities, and it's important that we think how these are promoted and delivered are done so in such a way is able to address the health inequalities. And we also want to reflect a little bit on the potential missed opportunity for broader health improvement in terms of thinking about the broader health and wellbeing of gay men who are currently who've been part of our surveys. So within Scotland, we have a very broad-ranging sexual health and bloodborne virus strategy, which goes beyond a focus on trying to reduce the number of infections or unintended pregnancies, to commit to try to reduce health inequalities and promote sexual relationships that are free from coercion and harm, and really encourage a society that is positive, non-stigmatising and supporting. And to impact on these broad health inequalities, we believe that you need to go beyond HIV and beyond sexual health. So we know that gay men experience a disproportionate burden of ill health in relation to not just sexual health, but also mental health and substance use. These data from the NATSAL survey, which is a national probabilistic sample across Great Britain, has demonstrated that 46% of the gay men who have sex with men within that survey reported two or more health inequalities, and 10% of men who identified as gay within the survey reported all three. So that's the reported outcomes that evidence poor sexual health and mental health and substance use. And this compares with just 1.5% of men who had sex exclusively with women in that sample. So reflecting on this interrelationship between different health outcomes brought me to consider syndemics as one way of trying to understand what's happening. So syndemics is a term that's given to the co-occurrence of multiple interrelated disease epidemics at the individual and population level, which develop and are sustained due to harmful social contexts. The approach tries to account for the social, environmental and other structural and cultural contexts that are driving or sustaining negative health outcomes. And there's two key theoretical concepts within it. The first is that of disease interaction, and the second is the role of the social. So in terms of understanding disease interaction, there's a lot of parallels here with multimorbidities research. So looking at the co-occurrence of more than one, often but not always chronic disease within an individual. However, reflecting on multimorbidities research, we see that often the focus is on individual disease management and treatment and care pathways, and trying to understand the causal connections between different health conditions. In prevention research, it very often focuses on the individual as opposed to population or community-based interventions. So the presence of comorbidities is not enough in itself, and syndemics tries to move beyond this solely biomedical focus by trying to understand the social conditions that are underlying disease and ill health. So each health condition in the syndemic is in turn affected by the often detrimental social conditions in which people live. We know that health conditions concentrate in particular populations, and they cannot be viewed as a biological process alone. As a result of this, the syndemic is likely to be locally determined and affected by the particular social conditions of a given location or population, and variations within the health and social care in these particular locations or that populations experience. Globally, social inequalities exist because of unequal distribution of resources, whether in that one section of society is privileged over another as a result of class, gender, age, ethnicity, sexuality, or other power relations. And social inequalities then determine that particular sections of society are subject to often substandard or unstable living conditions, restricted access to adequate and healthy diets, and reduced access to medical care and public health improvements. Also more likely to experience structural violence and stigma and discrimination. So syndemics, which was first advocated in the US, was first used to try and understand the interrelationships between substance use, violence and AIDS experienced by gay men in inner city areas of the US. It's since been evidenced amongst people who've experienced gender-based violence, broadly amongst MSM and amongst drug users and sex workers as well. There's extensive literature, mainly from the US, that seeks to evidence syndemics amongst gay, bisexual and other men who have sex with men, or use the theory as a way to understand health outcomes. However, it's not without its problems. So at the moment, most studies can only present correlations or associations between different, primarily mental health and psychosocial health behaviours and outcomes that make up the syndemic. Others have examined whether groupings of different health behaviours have a syndemic effect on a particular outcome, most often HIV or sexual risk behaviours. Very few studies have tried to examine the syndemic as the outcome itself, i.e. the presence of the interaction between health conditions and a greater burden of ill health experienced because of it. Few studies have truly addressed the role of social context beyond basic demographics either. So there's a real absence of evidence to demonstrate how syndemic health inequalities amongst gay men are driven by the negative and pathogenic social context in which some live. So few studies have been able to truly look at the experience of homophobia, stigma and discrimination, or social isolation. And few studies have addressed how to intervene to develop interventions that are able to address the co-occurrence of the multiple health problems together. So there's a real lack of evidence on how to counter syndemic ill health. So using data from one of our surveys of gay men within Scotland, we sought to try and see if we could evidence syndemic ill health within the population who took part in our survey. So this draws on the online survey, SMASH2, which was completed in 2016. It includes data from gay men surveyed within Scotland, Wales, Northern Ireland and the Republic of Ireland, so everywhere but England for our survey. We had a sample of just over 2,900 men, and we included a range of different measures within the survey. Going beyond the bar survey that we conducted, that I've been drawing on so far, was limited by having a short questionnaire and a short time period within bars for men to complete the survey, and focused very much on the experience of HIV testing and some sexual health measures. In the online survey, we were able to collect more data that focused on a range of sexual, mental and physical health outcomes, along with the related behavioural or health drivers for these. We included a measure of social isolation and the experience of stigma and discrimination, and also a measure of resilience using the sense of coherence scale, and I'll come back to that later in the presentation. We derived a variable, a measure of syndemic ill health to reflect the experience of having 2 or more health outcomes. So we looked to see whether poor sexual, mental and physical health outcomes and harmful behaviours did cluster within and across the health domains. Just under 2 in 5 men in the survey reported the experience of negative sexual, mental and physical health outcomes. So that's the experience of all 3. And when examining all 3 outcomes concurrently, all were clustered with greater prevalence than expected if the outcomes were independent. We went on to look at whether or not syndemic ill health was associated with the experience of stigma and discrimination and social isolation, based on the hypothesis and drawing on syndemic's theory that it's this negative context that drives syndemic ill health. However, in our multivariate analyses, social isolation and stigma and discrimination were not significant when combined with the syndemic health drivers and controls for socio-demographic covariates. The factors that did remain significant in the multivariate models were financial hardship and physical and sexual health behaviours. So we've reflected in terms of trying to understand why this might be the case. And we know that societal and community norms have changed markedly over the last 2 decades. And the countries included in the SMASH2 survey have all witnessed significant steps to increase, albeit legislative, sexual and gender equality. So it could be in these contexts that actually the experience of stigma and discrimination are not as significant in men's lives as the experience of financial hardship, which we all know has had an impact, particularly in terms of the times of austerity that we live within. However, that's not to say that gay men and others within the LGBT population within the UK don't experience stigma or discrimination. This survey that came out just last week and included over 100,000 participants found that at least 2 in 5 had experienced an incident because they were LGBT. This included verbal harassment and even physical violence. Understanding the impact of this on health and on syndemic health in particular is important, but clearly not yet fully addressed. Reflecting a little bit more in terms of our understanding of social isolation, we've drawn on much research that's come out of Australia in terms of how we think about how gay men engage with the communities around them. We know there's been changes to the structure of gay communities and to patterns of socialisation for all of us in terms of how we connect socially and sexually. So Nicola Boydell, my PhD student I mentioned earlier, she conducted a study to try and understand how young gay men within Scotland engaged with their personal communities, engaged with gay communities round about them, and what impact this had on them in terms of their access to an awareness of HIV testing and also broader sexual health. She used this methodology to ask men that took part in qualitative interviews with her to map out the people who were important to them within their lives. And the placement on the circles, so the interviewees in the centre and the placement in the circles demonstrates how important someone is to them within that. The colours demonstrate different friendship groups, including partners, families, gay male friends, straight male friends, female friends, etc. So what Nicola found was that the young gay men's communities were very complex and diverse. Many of the young men had very highly mixed groups of friends, both in terms of sexual orientation and in terms of gender. And men articulated an understanding of gay communities and an engagement with this, but it wasn't framed as a central organising factor in terms of their personal communities. Their understanding of safer sex and HIV testing was shaped by social norms around them and within their personal communities and the wider gay community that they were exposed to as well. So this slide just gives you a sense of the complexity of the communities and how men talked about community within their lives. I don't expect you to read it all, of course, but it just demonstrates the diversity of experience in terms of connection to community. And this really questions the centrality of a quite narrow measure of social isolation or marginalisation as a syndemic driver for gay men. I think we need to do more work to really understand what this means for men, and I'm quite keen that what follows on from the work we've been doing that I'm presenting here is some more qualitative research to try and understand what syndemics might mean to men and also what the solutions might be to that. So to finish off then, I'll just reflect a little bit in terms of the solutions that we might look to. So this report came out quite a few years ago now from Public Health England, and it reflected on the idea of the syndemic and the overlap between mental health and wellbeing, between alcohol and drug use and the experience of sexual ill health. However, the report was only able to set out interventions that address sexual health, mental health and substance use separately. So few studies have been able to address the co-occurrence of psychosocial problems, substance use and sexual and mental ill health. None of the available evidence that we have found has considered how we might deliver multiple interventions in tandem to address these outcomes. The inequalities that are experienced by gay and other men who have sex with men are complex, and their health improvement will likely require complex interventions as well. In thinking about next steps forward, we've reflected on how community responses to HIV have long been linked to successful HIV prevention with gay men. Creation of safer sex amongst gay men in the 1980s as a response to HIV and largely credited to gay communities themselves represents the best recorded evidence of population behaviour change. There's extensive evidence of the success of peer and community engagement in facilitating sexual health improvement and HIV prevention. And colleagues in the US who've conducted work around syndemics have also reflected on how a better understanding of resilience or the strengths within a population may be a way forward for us in terms of improving health, and would be better for us to focus on than trying to always address the vulnerabilities amongst men who reside in high-risk contexts. So this brought me to reflect on some of the work that's came out of the Glasgow Centre for Population Health, which is one of the partners within the institute that I work within. And they've done a lot of work in terms of trying to understand community assets and engaging with communities directly to help communities themselves find the answers that they need and find the solutions to whether it be health or other issues within those communities. The approach is a very general framework, and as it says, is about engaging with the community for them to find their own solutions. But it sees the people who live within the community as the answer and wants to support them to develop their potential way forward. It focuses on the strengths within that community and invests in people as being active participants in the development of their own interventions. It helps people to take control of their own lives and really starts with the assets and resources that are available within the community setting that it's engaging within. However, evidence of effectiveness of this approach is still limited and very much centred on physical communities. It's largely absent from health improvements efforts with gay men so far. So reflecting again on the SMASH2 study, we wanted to try and see if we could evidence the idea of strengths or assets or resilience within the population within the survey to find out whether that had a protective effect on syndemic ill health. Were men who had greater resilience less likely to report syndemic ill health? For this, we used Antonovsky's sense of coherence scale, which measures the understanding, manageability, and meaningfulness of life. It's a standard measure of resilience. And what we found was that, as we hypothesised, that those men who had a higher sense of coherence, so that is, were more resilient, had lower odds of syndemic ill health. So this provides empirical evidence that perhaps capitalising on and promoting such community assets could indeed be a means of countering syndemic ill health. So just to summarise then, over a third of men who took part in the SMASH2 survey reported experience of all three negative mental, physical and sexual health outcomes. It suggests an unmet need for health improvement that goes beyond anything that biomedical HIV prevention can provide. And we've demonstrated a theoretical mechanism by which assets or strengths could function to reduce syndemic ill health. However, sense of coherence could be argued to be just one measure of a very limited form of resilience within a community, and one that's very much focused on the individual. There's also been some really interesting work by Jackie Gahagan and colleagues in Canada, which has reviewed the various measures and definitions of resilience that have been used in research with LGBTQ communities. And they conclude that these measures continue to be contested and actually considered inadequate at considering the intersection between individual social and structural inequalities that LGBTQ communities face. So again, this is why we're thinking that we need to step back, do some qualitative research, and really try to understand what communities themselves see as their strengths and their resiliencies as a way forward. So can we develop a new community asset-based model of syndemic health improvement? I would certainly like to think that we can, and to do so we need to first focus on the individual to build sustainable resilience, coping and wellbeing amongst those who are most vulnerable within our communities. We need to capitalise on the support of salutogenic social networks around them to increase community assets, and then also address the structural determinants of syndemic inequalities at the community level, and seek to build on the strengths and the assets of the communities as a whole in which we live. So to finish off, I'll just briefly reflect on some future directions for this work. So we really need to now work with communities to fully understand and inform an assets approach for syndemic health improvement interventions. Last year, The Lancet published a series on syndemics and the opportunities for it as a way forward within the field. It talked about the need to broaden the use of syndemics beyond HIV to include non-communicable diseases. that it could be used as an application in terms of how we understand the health problems faced in low and middle income countries, and as a means of understanding and preparing for the health implications of rapid globalisation and the political changes and economic uncertainties that affect so many of us. So I think this endemics framework could and should be applied more broadly. And in order to do so, I reflect just on the quote that accompanied the Lancet series. For multiple reasons, human rights reasons, public health reasons, reasons of health equity, the protection of vulnerable people from syndemic suffering is both an urgent need and a fundamental matter of social justice. This brings me full circle back to where I started in terms of saying that we really need to focus on the social determinants of health and understand these if we are to intervene to improve health. We know that the experience of health is driven by the profound inequalities that some in our society experience, and efforts to improve health needs to be salient of these. We need to understand the lived experience of marginalised communities and populations and work together to identify the means of countering syndemic ill health. I will finish there, hopefully with some time for questions, and just acknowledge the very many people who've been involved in the work over the years. Thank you.
Hi, I'm Karen Fisher. I'm a Social Policy Research Centre Disability Policy Researcher. So I'm really interested in syndemics. I've never heard of it before. So I've got a fairly basic question. The aspect that we're interested in these overlaps and health outcomes, along with other outcomes, is the role of the health services and the accessibility and responsiveness of the health services. Can you talk about how that fits into the syndemics story?
Yeah. So I think you could see that very much in terms of understanding the context that people experience in relation to their health. So access to services could be part of that. Reflecting on some of the early work in terms of syndemics, it did talk about the early study focused on how, particularly within the US context, the men who were experiencing syndemic ill health had no access to health services or very limited access to it. So you could see it within that part of the model.
So how does that help us, though, in terms of when you're saying using syndemics to address the problems? If the problems are actually in the health service part of that, how do you fit that in that theory?
So I suppose it's about reflecting on how that is one of many other issues the population might experience. So I don't know your field, but thinking through, are there multiple health outcomes, and then what might the issues be, and is access to health services just one of them? What might the others be? And thinking about how you would put them together in terms of understanding the model. What we've done with the research with gay men is reflect on the overlap in terms of sexual, mental and physical health, and then the drivers of that. So it's about kind of stepping back to the population or community that you're working within and thinking about what is the model that you would want to put together to try and understand that.
Thanks. Thank you. Anthony Zui, School of Social Sciences at UNSW. Thanks very much for that overview. To some extent, and perhaps you can correct me if I'm wrong, you seem to have presented gay and bisexual men as a sort of single community. And my question is whether there are subgroups or sub-communities in which, you know, the approach talking about syndemics might be more useful. For example, looking at, might be people of colour, it might be, you know, people who are affected by, let's say, refugees and asylum seekers, people from Europe, low-paid workers, etc. So could you comment on that?
Yeah, no, absolutely. It's not my intent to present all gay men as one group, and that's really just a reflection of trying to get through lots of data in a short space of time. I think absolutely there are very many different gay communities, and what the syndemics might enable us to do is, as you say, think about the experience of health or the inequalities in health within particular groups who may have different issues around access to healthcare, for example. So I think that's probably part of how we would want to think about modelling health improvement going forward. I definitely wouldn't think it would be a case of kind of one size fits all and one intervention would work for all. And kind of reflecting on one of the earlier slides in terms of understanding that the experience of syndemic ill health is likely to be very localised in terms of a particular population or a particular community, and it's about working with that community to understand what the syndemic is and what the strengths are to take that forward. So I would see any intervention that you might want to develop as being very much community driven, and there are very many different communities.
Thank you for that. My name is Rob. Hi. What about all the stuff 30 years ago, 40 years ago, we were always doing called community development, peer education, learning circles, empowerment circles, transformational learning activities? How does that fit in? Because all of that was very theory driven, but we know it worked because we did it. So how does it link in now with these fancy schmancy things around syndemics and all of that? Are they methodologies that you could borrow from, or where's the place? Where's the match with those?
I absolutely think that there are methodologies that we could be considering and drawing from. To me, syndemics is one way of trying to operationalise and understand, have a better model of how we understand and address social determinants of health within particular populations who are marginalised and experiencing very poor health. I think what we need to do is try and understand what the community development model, what the peer model might be going forward. One of the first pieces of work that I was involved in as a junior research assistant back in 2000 in the unit was an evaluation of a peer-led intervention for gay men that had been conducted in Glasgow. It took the popular opinion leader model from the US and had developed it and applied it within the context within the Scottish context within Glasgow bars, and it didn't work. And when you reflect on why it didn't work, of course it didn't work, because it took an intervention from one context and put it into another. And you really need to think about how interventions transfer between contexts and how we might need to develop things further. So I think at the moment, in terms of my work, one of the next key questions that I have is what are the models going forward and who are the peers? So reflecting on my student Nicola's work in terms of understanding personal communities, that came out of a desire to try and understand how young gay men in Scotland were engaging with gay communities to think about a peer model for health improvement. What we then took from that was, well, who are the peers and how would we develop that further? So I think to me the next logical step is about engaging with communities to find out what model they think might work. Look at the options that are available, very much drawing on what's been done before. No one wants to reinvent the wheel when it comes to doing this type of work, and really work with the communities on the ground so that they have a say in how it's developed.
Thanks, Lisa. Martin Holt from the Centre for Social Research in Health. You're taking syndemics theory in a slightly different way. It's making me think about the politics of why syndemics theory was developed in the US, which you may not have an answer to, but you could perhaps reflect on. Or I'm wondering, you're talking about translation of interventions. I'm actually thinking about the translation of theory, about whether it has fidelity or it works. And syndemics theory is an odd one in the US, where you could almost argue it was developed to try and draw attention to the total lack of a welfare or public health safety net in some settings. And in some ways, reaction, say, in Australia was not so positive to syndemics because it was seen as just kind of like an orgy of pathology that was revealed in certain marginalised populations. that whether that was actually politically useful. And so actually they're kind of focusing on assets and resilience, which is part of the response to the critique, kind of works better in settings where they think that there is actually some degree of population engagement that can be harnessed. So I was just wondering whether perhaps you could comment on why you think that syndemics theory works in some settings, or what you think you can achieve from it by kind of taking it in a slightly different direction, or this Lancet direction.
Yeah. Oh, yeah. Good question. Yeah. Thanks for that. So to me, I reflect on syndemics as an opportunity to really think about how some of the most marginalised in our society are experiencing poor health. So I come from just outside Glasgow. I have spent all of my adult life there as well, and you can't live in that context without realising and being very much aware of that some have health and wealth and opportunity and some don't. It's a society that is very driven by inequality, and that is all around you. And despite very many efforts over a very long time period, that really hasn't changed. So to me, syndemics is one way to perhaps just refresh that, to think about, well, can we take a slightly different approach to this? I think it does draw on and borrow on other theories, and I completely accept your point about where it came from. But I think going forward, it is one way to really kind of try and operationalise and understand the experiences of the most marginalised in our society. And I'm keen to see if it is one that we can draw on to then develop a very much strengths-based positive approach to improve health. I'm not sure that answered your question or not.
Very, very quickly.
Yeah.
Hi Lisa, it's nice to hear the mother tongue. So I'm Cheryl, I'm the Community Partnership Officer at South Eastern Sydney Local Health District. Week number 7 for me, new to the job, but it's not so much a question but a sharing of information, where I've been employed to do that community development stuff for health within the Community Partnership Unit, and it's very much about asset-based community development. One of the projects I'm working on just now is actually the HIV Stories project, where we're recruiting people with a lived experience of HIV to help co-design our new 5-year model of care plan going forward, and that for me that's highly relevant. The other piece of work we're involved in is exactly that, going into the communities, and the best thing I heard from the community was whatever the question is, community has the answer. And that's a place-based approach. So it is happening, it's only week 7 for me. So just to say it is happening. And I'm from Kilmarnock, so I get the health inequality stuff, by the way.
Yeah.
So thank you.
And it's really great to hear that it is happening. And I think there are some really good examples out there. And I've been in Australia for just coming on a month now. And I think one of the things that's really struck me in terms of the research that's happening here is that commitment to engaging with communities and really kind of working from the ground up in terms of co-design models going forward. So, and I would definitely say you're ahead of what we are in the UK in terms of that model from the work that I've been involved in anyway. So.
I think we have to wrap up, but please join me in thanking Lisa.